Welcome back to my channel. Why does fluid collect around the lungs? That fluid is known as pleural effusion. Let's decode it in a simple and visual way. The accumulation of serous fluid within the pleural space is termed as pleural effusion. The accumulation of frank pus is termed as emphyema, and that of blood is hemothorax, and that of child is chylothorax. Pleural effusion is mainly of two types, transudative and exudative. The pleural fluid accumulates as a result of either increased hydrostatic pressure or decreased osmotic pressure is known as transudative effusion, which is seen in cardiac, liver or renal failure, or from increased microvascular pressure due to disease of pleura or injury to the adjacent lung is exudative effusion. The causes of majority of pleural effusions, most common causes are pneumonia, tuberculosis, pulmonary infarction, malignant disease, cardiac failure and subdiaphragmatic disorders. And most uncommon causes are hypoproteinemia, in which the nephrotic syndrome, liver failure or malnutrition is involved, connective tissue disorders, particularly systemic lupus erythematosus and rheumatoid arthritis, post-myocardial infarction syndrome, acute rheumatic fever, uremia, myxedema and abscesses-related benign pleural effusion. Let's learn it in a detailed way. If the pleural effusion is caused by tuberculosis, the fluid appears as a serous, usually umber colored. It is exudate type of fluid, and in this the predominant cells are mostly lymphocytes and occasionally polymorphs. The diagnostic feature in tuberculosis are positive tuberculin test, isolation of Mycobacterium tuberculosis from pleural fluid, positive pleural biopsy and raised ADA. If the pleural effusion is caused by malignant disease, the fluid appears as a serous, often blood-stained. It is the exudate type of fluid, and in this the predominant cells are serosal cells and lymphocytes. Often clumps of malignant cells are seen. The diagnostic feature of malignant disease is positive pleural biopsy and evidence of malignancy elsewhere. If it is caused by cardiac failure, the fluid is serous or straw-colored. The type of fluid is transudate. In this, the predominant cells are few serosal cells, and the diagnostic feature is other signs of cardiac failure which responds to diuretics. If it is caused by pulmonary infarction, the fluid is serous or blood-stained. It is the exudate, rarely transudate type of fluid, and the predominant cells are RBCs and eosinophils. The diagnostic feature is evidence of pulmonary infarction, obvious source of embolism, and factor predisposing to venous thrombosis. If pleural effusion is caused by rheumatoid diseases, the fluid is serous turbid if chronic. Mainly serous fluid is there, and if it is chronic, it may be turbid. The type of fluid is exudate, and predominant cells are lymphocytes, occasionally polymorphs. The diagnostic feature are rheumatoid arthritis, rheumatoid factor and anti-CCP antibodies, cholesterol in chronic effusion and very low glucose in pleural fluid. If it is caused by SLE, that is systemic lupus erythematosus, the type of fluid is exudate, and in this the appearance of fluid is serous. The prominent cells are lymphocytes and serosal cells. The diagnostic feature are other signs of SLE, anti-nuclear factor or anti-DNA positive. If it is caused by acute pancreatitis, the fluid is serous or blood-stained. The type of fluid is exudate, and in this the no cells are predominant. The diagnostic feature is higher amylase in pleural fluid than in serum. If pleural effusion is caused by obstruction of thoracic duct, the appearance of fluid is milky in color. The type of fluid is chyle, and in this the predominant cells are not seen, and diagnostic features are chylomicrons. Investigation. Radiological investigation. The classical appearance of pleural fluid on the erect PHS film is of curved sharrow on the lung base, blunting of costophrenic angle and ascending towards the axilla. The fluid appears to track up the lateral chest wall. In fact, fluid surrounds the whole lung at this level, but casts a radiological shadow only where the X-ray beam passes. Around 200 ml of fluid is required in order for it to be detectable on PA chest X-ray. Ultrasound is more accurate than plain chest X-ray for determining the presence of fluid. A clear hypoechoic space is consistent with transducet, and presence of moving floating density suggests an exudate. The presence of septation most likely indicate an evolving emphyema or resolving hemothorax. CT scanning is indicated where malignant disease suspected. Pleural aspiration and biopsy. In some condition, example left ventricular failure, it should not be necessary to sample fluid unless atypical features are present. Appropriate treatment should be administered and effusion re-evaluated. In most other circumstances, however, diagnostic sampling is required. Sample aspiration provides information on the color and texture of fluid, and these alone may immediately suggest an emphyema or chylothorax. The presence of blood is consistent with pulmonary infarction or malignancy but may result from traumatic tap. Biochemical analysis also allows the classification into transudate and exudate, and gram stain may suggest parapneumotic effusion. The predominant cell type provides useful information and cytological examination is essential. A low pH suggests infection but may also be seen in rheumatoid arthritis, ruptured esophagus and advanced malignancy. Ultrasound or CT-guided pleural biopsy provides tissue for pathological and microbiological analysis where necessary video-assisted thoracoscopy allows visualization of the pleura and direct guidance biopsy. The Light's criteria for distinguishing pleural transudate from exudate. Exudate is likely if one or more of the following criteria are met. Pleural fluid protein serum protein ratio is more than 0.5. Pleural fluid LDH and serum LDH ratio is more than 0.6. Pleural fluid LDH is more than 2/3 of upper limit of normal serum LDH. Management of pleural effusion is therapeutic aspiration may be required to palliate breathlessness. Removing more than 1.5 liter at a time is associated with small risk of re-expansion pulmonary edema. The effusion should never be drained to dryness before establishing a diagnosis. We have to treat the underlying cause of pleural effusion. Example, heart failure, pneumonia, pulmonary embolism or subphrenic abscess will often be followed by resolution of the effusion. That was a complete overview of pleural effusion. If you found this helpful, don't forget to like, share and subscribe for more medical concepts simplified.